Good evening. Today is July 15th, 2020, and it is 5:32 p.m. As a quorum of the Board of Managers is in attendance via a video conference, I would like to call to order this meeting of the Central Health Board of Managers. We will start with public communication, which is our first item of business. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 4 p.m. today. Jana, did anyone register to make comments today?
Yes, Madam Chair, we have one person signed up for public communication, and that's Holly Gummert, and they are familiar with all of Central Health's public communications policy and procedures.
Indeed, Ms. Gummert is, so please proceed.
Good evening, board members. I am here tonight to share with you a change that I have been anticipating for some time, which is that Mr. David Duncan will be serving as primary Open Meetings Act counselor to the managers at board and committee meetings. Most, if not all of you, have had the opportunity to work and get to know David over the past year. But many may not be familiar with David's professional history prior to his tenure at the Travis County Attorney's Office. David has spent much of the past 3 decades advising Texas governmental entities on various matters, with his most recent role being that of General Counsel to the Texas Department of Motor Vehicles. In his time at DMV, and before that at the Texas Comptroller of Public Accounts, David has reviewed and approved countless agendas and overseen numerous executive session briefings. David is also board certified in administrative law, which requires an attorney to have substantial involvement and special competence in representing clients before administrative agencies, practicing law within those agencies, handling judicial proceedings involving those agencies, and most importantly for you, extensive knowledge of the Open Meetings Act. Needless to say, David is quite qualified to assist Central Health in the role of Open Meetings Counselor, and I have no doubt that you will find him to do an exceptional job at it. I will of course still be available to the managers and in attendance at most meetings, but will leave guidance regarding compliance with the Open Meetings Act in David's capable hands. Before I do that, I want to take a brief moment to thank Mr. Gieslin for allowing me to place David in this position, and of course the board for placing their trust in me over the past 4 years. Many of you know this is my first job out of law school, and I have grown quite a bit. It has been an honor working with each and every one of you, and I look forward to continuing our important work together over the next fiscal year. Thank you.
Thank you very much. I know that well, speaking on behalf of myself, and I'm assured the other board members, I am sure we are very grateful for all of your guidance, help, and assistance. We look forward to continuing to work with you in as part of the Central Health family. And David, we have enjoyed getting to know you and appreciate your expertise and look forward to working with you in this role. So thank you very much. Is there anyone else who has signed up for public communication?
No, Madam Chair, this concludes public communication for tonight.
Okay, thank you very much. So we will now proceed to the consent agenda. We have 3 items on the consent agenda. Item number 1, approve the minutes of the Central Board of Managers April 22nd and June 24th, 2020 regular meetings and June 25th, 2020 special call meeting. C2, approve delegation of authority to the President and CEO to execute a contract to purchase furniture, fixtures, and equipment for the new eligibility call center. And C3, receive and accept the June 2020 financial statements for Central Health and the Community Care Collaborative. Is there a motion that anyone wants to make at this time? Is someone, Manager Bell?
Manager Valadez was trying to make the motion, but she's
Manager Valadez, could you unmute?
There you
go. I move that we adopt consent agenda items C1 through C3 for yes, it is.
Is there a second? Manager Bell? So we have a motion by Manager Valdez and a second by Manager Bell. All in favor, raise your hand. All opposed, same sign. Any abstaining? Okay. Thank you, board members. The motion passes. We will now move to the regular agenda. Item number 1, discuss and take appropriate action on the appointment of a new Central Health Compliance Officer as nominated by the President and CEO pursuant to Central Health Compliance Policy CMP-003. And Monica Crowley and Mike Gieselin will be presenting on this item. So I will turn the floor over to them.
All right. Thank you, Madam Chair and members. We are excited to introduce and recommend Mackenzie Frazier as the compliance officer for Central Health. He recently joined Central Health and brings a wealth of compliance, especially in the healthcare arena, which is something that we need. So as a leader for compliance, but also ethics within the organization, we look forward to working with him and hope that you will support our recommendation to approve his being named compliance officer for Central Health. And I'll hand it over to Monica.
Monica Crowley, Chief Strategy Officer and Senior Counsel at Central Health. And I second Mike's excitement about Mackenzie Frazier joining Central Health. He came to Central Health. There is a memo and his resume. And so I'm not going to go through his entire resume, but I just want to highlight that Mr. Frazier comes to us from People's Community Clinic. He has extensive compliance credentials, not just on the clinical side, but in the health plan side, and also I think in the healthcare setting, something that's really important on the regulatory side, both on the state and the federal level. And I just would like to say that in the past couple of weeks since Mackenzie's been with us, he has really hit the ground running and has, just gone out and virtually met with many of the department leaders at Central Health and is already just going through all of the policies. And I'm very confident that if you approve Mr. Gieselin's recommendation to make Mr. Frazier our compliance officer, that he will continue to enhance and expand our compliance program. And I am very excited to recommend Mackenzie to you tonight.
Well, thank you, Mr. Gieselin and Ms. Crowley. I certainly am ecstatic to have Mr. Frazier as part of our Central Health family. Both his credentials and his experience are stellar, and I just think that he's quite an asset to Central Health. Board members, anything that you would like to add? Manager Valadez?
You needed a formal motion to move that we accept the recommendations and welcome Mackenzie Frazier. I was trying to see how long you've been here in Austin in Central Texas, but I'm glad that you came from California and Mississippi, and so you have a pretty well-rounded I didn't know if that was the time for this.
Thank you for the welcome, and I look forward to working with you all.
Sherry, you're on mute.
Thanks for letting me know. So we have a motion. Is there a second?
I second it.
Okay, we have a motion by Manager Valdez, a second by Manager Bell. All in favor?
Aye.
Hands, aye. Opposed, same sign. Any abstaining? Wonderful, unanimous. Welcome, Mr. Frazier. Very happy to have you here. Round of applause, virtual. Okay, thank you so much. With that, members, we will move to item number 2 on our regular agenda. Discuss Central Health owned or occupied real property and potential property for acquisition or lease, including next steps in the redevelopment of the Central Health downtown campus. Mr. Lamp will be presenting. Mr. Lamp?
Chair Greenberg, thank you. Managers, good evening. I am going to share my screen, hopefully, so bear with me one moment, please. Okay, all right. Hopefully that is showing. Basically, it's a schematic of the downtown property.
Yes,
There's
it's
also a memorandum included in the board package, which is more a list of discussion points. And I will try to go through these rather quickly. Quickly for an update, we have completed the Clinical Education Center project. That is, and I will try to move my cursor slowly, but that is our northeast corner of the property. The CEC, or the Clinical Education Center, is leased to Seton through September of 2024. That includes the sort of 3-winged building and the parking garage down below. The reason that the utilities project is significant is it allows us to decommission the central plant and close that out. The Central Health Master Plan actually had provided that maybe the central plant would be used to support the redevelopment of the campus, but it is antiquated. Austin Energy, several developers looked at it, and no one wants any part of it. So the providing dedicated utilities for the central plant has allowed us to decommission the central plant. So that is part of the ongoing step to prepare for subsequent redevelopment. We have also completed all asbestos abatement, at least of everything we can find. As you can imagine, this is an older building, and we keep finding chases and tunnels and pipes and things like that that we did not know exist. So we have encountered some additional abatement, but we have a continuing contract for the same contractor, and we have unit rates. So when we did hit, 6 weeks ago, some additional asbestos abatement. They were on call, we brought them back in. There is a 10-day notification period, but we can work around that. But anyway, all abatement has been completed to this point in time, which allows for demolition to advance. Now, demolition, block 164, which is our southwest corner. So I don't know if you can see the cursor. That is ground leased to 2033. They demolished the building on block 164, which had been a 4-story building. And the balance, this middle section in the central plant, are currently awarded and in demolition. We are not where I would like to be, candidly. It took us almost a year to obtain a demolition permit through the city regulatory process, which I won't comment on, just beyond expectation and duration. But we are advancing. I was actually on site today, meeting with the contractor, again, to the point that it's an older building and we keep hitting surprises. There are water lines that are active based on the pressure, but there's nothing that they connect to that we can find. So we have some ongoing challenges, but we are working through them. But I have also been trying to fire up the demolition contractor. I would like all work to be completed by the end of this year. 2 other activities are regulatory related. We've been working with the city of Austin to obtain a zoning overlay. So that will apply to the entire balance of the property. Now again, block 164, our southwest corner, and block 167 are leased to the 2033 Higher Education Development Foundation on behalf of UT Austin. So those are outside our purview, and those, because of the University of Texas's state agency status, they can do their own regulations and their site planning. But the zoning will apply to the balance of the campus. For a quick refresher, and I apologize if you want the short version, I will keep quiet. What we are doing right now, the property is zoned public. If Central Health was to develop a hospital or even an office building for Central Health use, our own use, we could claim state agency status as well and do expedited permit authority. But for commercial development, we want to obtain a central business district zoning overlay, and we are in negotiations with the city to obtain a 25-to-1 FAR, or floor area ratio. That basically will give us the ability, I don't know that there's a need, but again, this is not, there's been lots of discussion that, well, why do you need this right now? We don't know that we need this right now, but this is not a one-off option. I mean, we hope there'll be a one-off zoning action, but we're trying to set up the zoning for long-term benefit. So 50 years from now, if somebody wants 1.2 million square feet on each acre of downtown property, we can support that. There are many other challenges with that, but again, it's basically increasing the value and the potential on our property. Now, in tandem with the zoning overlay is a interlocal agreement for Central Health to front the cost to relocate Red River. So going back to the schematic, sorry, apologize that. So for orientation, 15th Street is the north of our property. The existing Red River is our western boundary. So it goes from 15th Street and extends down to 12th Street. This will be relocated, or basically straightened. So it's not perfectly straight, but more or less we will be straightening the road from 15th Street down to 12th Street. The portion of Red River Street within Central Health property, which extends from 15th Street to, if you're familiar with the Health South building is, actually just north of Health South building. There was previously a 13th Street that has been vacated. That is the Red River Street within our property. Central Health will be paying for that portion. That is essentially buying or prepaying into the downtown density bonus program. What that is hopefully will obtain for us is an increase of the CBD, the generic rating of 8-to-1 to 25-to-1. So it's actually a very prudent return on investment. It's also eliminating for any subsequent developer that might show up and have interest on this property, they don't need to go through that zoning process. So we're sort of capturing some additional benefit. The portion from Health South to 12th Street, Central Health is fronting that cost, but one of the negotiation points is that we do need to have definitive, limited timeframe reimbursement of all related project costs. Now, the ground lease that we have with the 2033 Higher Education Foundation, I keep saying Central Health is fronting the money. Well, we basically wrote it into the ground lease that 2033 is paying for all these project costs. So we have various options to recover or to pay our portion share. Right now, the plan is when construction starts, we will pay our pro rata share of the portion from 15th to 12th to, former 13th Street, the Central Health segment on a monthly basis. We've included that within the financial models. And the balance of 12th Street will have to be reimbursed by the city. So I apologize, that was maybe not the clearest definition, but I'm so familiar with it, I might be skipping some details, but I'll pause there and take any questions if you have anything.
Members, any questions? Manager Valadez? I think you're on mute. Manager Valadez, did you have a question?
No, I just wanted to make well, yes. Thank you very much, Stephen, for the report. Was I ever under the impression that we were going to try and see whether the city would negotiate reimbursing us for the entire Red River realignment or not? Maybe it was hopeful thinking.
It was hopeful. My initial premise was that, well, one, this is candidly more of a city initiative than a Central Health initiative because Hospital Drive exists. It's a little bit hard to see, but starting at 15th Street, if you follow the cursor, the arrow comes down and Hospital Drive turns out through block 164. Well, that turnout into the existing Red River needed to be relocated, so there is some interest in having this straightened. But really, it's part of our endeavor to cooperate with the city and overall entities. But our initial negotiations with the city were that, hey, you want the road, you guys pay for it. That was not highly successful for a long period of time, but we are trying to protect Central Health's interests as best we can.
Thank you. Anything else, members?
Just one last thing. Just one last thing. I know I brought this up maybe 3 years ago when we first started down this road with developing a master plan. Seeing whether or not as the building becomes demolished, the buildings become demolished, are there any opportunities to sell up Brackenridge brick? Just curious. For
like like what happened with the state capitol when it was refurbished?
That's exactly right. That's exactly right. So I was just curious.
Yeah. Okay.
Unfortunately, Brackenridge is actually precast and cast in place structural concrete, and it doesn't really come apart in nice clean chunks. We would have to saw cut it. There are some brick pavers that we had looked at salvaging, but the original hospital actually had been a red brick building from 1800s, I believe, and that has long been sort of usurped by uglier buildings, or I won't say uglier, they are construction of the period of the late 70s when concrete.
Enough said. Okay.
Got the picture, thank you.
Okay, Mr. Duncan, I believe we need to move into closed session now. Is that
I have a question.
Oh, okay. Sorry, Manager Jones, yes.
Just remind me, what is going to happen with that area from on the old Red River? That will be, once it's straightened out, what will happen to that? Will that be a mall, a pedestrian mall, walkway, or what?
Oh, no, very good question, sir. And I apologize, I meant to address that. The current concept is that The existing Red River waterway is approximately 80 feet wide. So as sort of a land trade or part of our reimbursement of the cost section that we are fronting, we hope to capture 55 feet of essentially the eastern half, a little bit more than the eastern half of the existing Red River. That'll extend from 15th Street down to probably what used to be 14th Street vacated. And then there's a slight section along block 164 that we also hope to recover. The balance will be returned to the city. The existing right-of-way will be vacated. It will become limited vehicle use, really only for use by emergency vehicles, possibly for some vehicles supporting activities at Waterloo Park and what will become the concert facility down here. But otherwise, it'll become a pedestrian plaza and support bicycles. Through traffic will not be allowed.
And we will recover that area, and will we do something on it, or it will be vacant?
We hope to be able to do something long-term on it, and that actually is one of the items I wanted to discuss in the next session.
Okay, all right, thank you.
Madam Chair, I believe you're muted. Sherry.
Sorry, managers. Anyone else at this point? I'm scanning, but I may miss something, so speak up. If not, I'm going to assume that we're finished with this portion of this item. Okay, I'm not hearing anybody shout out. So, Mr. Duncan, I believe we need to move into closed session now. Is that correct?
Yes, ma'am, for items 2 and 3, if you go
Correct.
ahead and read 3
Okay.
as well. Read
Yes.
the whole.
Will do. So I announce that the board is convening in closed session to discuss agenda item 2 under Texas Government Code section 551.071, consultation with attorney, and section 551.072, deliberation regarding real property, and agenda item number 3 under Texas Government Code section 551.071, consultation with attorney, and section 551.085, governing board of certain providers of healthcare services. So members, at this time, yes.
Madam Chair, if you could also read item 3.
Item number 3, yes, thank you. So I'll read both of them. So item number 2 is discuss Central Health owned or occupied real property and potential property for acquisition or lease, including next steps in the redevelopment of the Central Health downtown campus. Item number 3 is receive and discuss updates on the 1115 Medicaid waiver, delivery system reform incentive payment DSRIP close projects, and the community care collaborative, including healthcare delivery arrangements and other community partnerships. So at this time, members, everyone needs to completely get off of this meeting. So leave the meeting, and you should have received a link to the closed session meeting. Thank you. Right. T-minus 1 minute and counting. Okay, I'm looking to see if we have our quorum back. See Manager Valadez, Manager Zuniga, Manager Zamora, Manager Jones, Manager Bell. Okay, looks like our quorum is back. It is 8:15 and we have returned from closed session, so we are now back in open session. We are taking up, there was no action needed for the items in closed session, no motions necessary. So we are taking up agenda item number 4, and that is receive and discuss a presentation on the proposed Central Health and Community Care Collaborative fiscal year 2021 budgets, including related strategic objectives, developing trends related to the COVID-19 pandemic response, current fiscal issues related to Central Health, Enterprise Partners, Community Care, and Sendero Health Plans, Inc., and fiscal year 2020 end of year estimates. Members, I do want to say before we get into this, if we could listen to all of the presentations, and then I know it's lengthy, but just note your questions, please. And also, members, this is the beginning of our process. As I said, budget cometh, right? And this is the beginning. So know that this is hot off the press. We may have just received it, but staff is doing the very best that they can. And I talked to Mr. Giesel and Ms. Owens, and Ms. Owens has said that if you have additional questions, after this and while we're before our next meeting in August, she will be happy to speak with you or meet with you virtually. And so if you do want to do that, please get with Brianna, and Brianna will schedule those calls or meetings for you with Ms. Owens. And thank you for volunteering that, because she did volunteer it. Thank you for volunteering that, Ms. Owens. With that, I'm going to turn over to staff for this presentation.
Just a question, real quick question.
Yes.
So I don't see this in our packet. That's something that they just emailed us. Is that what you're telling us?
Ms.
This
Owens
proposed
or Brianna?
It was sent out in an updated packet, I believe,
Yes.
this afternoon.
Exactly. And that's why I was saying it's hot off the press, but this is just an initial. There'll be plenty of time to study it. And if you'd like to have follow-ups with Ms. Owens, just let Brianna know and she'll schedule it.
And can I just check that you can see my screen?
Yes,
the budget
ma'am, we can
presentation?
see it.
Okay, great. Thank you. I think
Yeah, I'll kick off.
Jeff's here. Okay.
Jeff Knodel, and I'm joined by Lisa Owens and John Morgan. And thank you for the introduction. The budget is hot off press. And thank you, Lisa, for volunteering. Any of us are available to meet, to go over questions. Our next meeting is in August. So we know there's a big time period, and we would be certainly available to sit down and go through detail and answer any questions. So indulge me for a second. I'm going to do a quick intro, and then we will briefly go through slides. I know it's getting late. This is our proposed fiscal year 21 budget presentation for Central Health and the Community Care Collaborative. Included in your packet was a memorandum that discussed the Community Health Initiative funds and a draft budget resolution that we will work on throughout the budget process through September. Our community has faced and continues to face the COVID-19 healthcare crisis. During this period, Central Health, Community Care, and Sendero have worked diligently to prevent the spread of the virus. Under your leadership, our community has had access to drive-through testing and an information campaign to inform the community on steps to take to prevent the spread of the virus. In addition, costs for testing and treatment of COVID-19 have been waived to community care patients and Sendero members. The devotion and efforts of the staff of all Central Health entities has been endless and has helped bring services to the most vulnerable population in this time of need. During fiscal year 20, despite the COVID-19 outbreak, improvements to specialty care have occurred. Most notable improvements have been in gastroenterology. Despite these areas of improvement, significant improvements remain to be had in many other areas. As we've seen in the past few years, healthcare funding has undergone many changes. With these changes, in addition to recommendations made by the Germain Performance Review, Central Health has begun to transition to a more direct payment model to fund healthcare services. We have been in mediation with Ascension, Texas on a hospital payment model. We don't anticipate reaching an agreement in fiscal year 20. However, we remain hopeful that both parties can come to an agreement in fiscal year 21, although we will need to be flexible in the event an agreement is not reached. The proposed fiscal year 21 budget was prepared with a tax rate of 6.9% over the no new revenue rate, which equates to a rate of 6.5% plus an additional 0.4% to fund the Community Health Initiatives Fund. This rate will result in a tax rate of 10.86 cents per $100 of taxable value and will result in an annual increase of $19.54 for the average homestead, the average taxable homestead value of a little over $355,000. Lisa, if you'll turn the slide, we'll get rolling on the presentation, and I'll have the first few slides, and then I'll turn it over to John Morgan. You guys have seen this slide before. This is 2019 data related to tax rates in major Texas hospital districts and the corresponding tax burden of the hospital districts within those taxing jurisdictions. We will update these rates for 2020, but notably speaking, you'll see tax rates anywhere from a little over 10 cents, which is the Central Health rate, to 27 cents. And again, a tax burden anywhere from a little over 4% to 10% and above. Next slide. So this is a quick chart of the history of taxable values in Travis County. And the red line is the tax rate, corresponding tax rate for the year. You'll see that the tax rate in itself has declined over the last several years and has flattened out. And then you'll see the constant taxable growth that has occurred in Travis County over the last several years. Noting that the fiscal year or the tax year 20, these are tax years. This is a preliminary number and will be updated once we receive the certified roll. Next slide. So this is our slide of our proposed tax rate that I just covered in the intro. You'll see the breakout of the tax rate. Our aggregate tax rate is 10.86 cents per $100 valuation. Again, the increase to the average taxable homestead value is $19.54. And just as a reminder, we retain the exemptions that we've had last year. We're at the maximum homestead value of 20% for the local exemptions, and then other local exemptions related around the over 65 and disability exemptions are at $85,500. Next slide. So we kick off the budget process doing our 7-year forecast. We estimate where we'll end up in fiscal year 20. We estimate what the proposed budget will look like, and we look at reserves over the course of the next 7 years with known events. We have updated our numbers related to our estimate that Lisa will go over. We look at our metric of days of cash on hand. That's an important metric that we want to look at, and you'll just see the trend, which is beginning with our fiscal year 20 estimate and moving into fiscal year 21, a large number of days of cash on hand. but as time goes, the days of cash decreases. A lot of that decrease is related to the transition of costs that are currently being funded through our DESRIP program in the Community Care Collaborative. We anticipate those costs moving over in fiscal year 23. You'll see subsequent, our budget becomes unstructural, and it's not until fiscal year 26 that we become structural, where sources are equal to or exceed our uses, and you'll see the corresponding increase in our days of cash on hand. And that's the intent of this analysis, is to look at a long-term analysis of our reserve levels and where do we end up at the end of this period. Are we continuing to trend down, or have we addressed any issues during this period and we're looking at a favorable trend moving forward in the future? That gives us a lot of flexibility in the future to accommodate a lot of the healthcare funding changes that we have seen over the past few years. Next slide. There are a number of risks in healthcare financing and in healthcare general. I've just listed a few that are out there just as a reminder, although this certainly is not an exhaustive list. Certainly COVID-19 is a continuing risk. Questions like how long is it going to last? Does the infection rate start to decrease? Do we have increased infection rates during the fall, during flu season? There's a lot of risk related to the ongoing pandemic related around the COVID-19. There's been a lot of discussion about a vaccination, but how is it distributed? What's the timing? Who gets that? That's another that just prolongs the time period related around COVID-19. The hospital funding model, currently in our existing agreement, Central Health does not assume hospital risk. We are looking at a more direct payment model. In hospital services is one of those areas. Certainly the risk for not only the hospital cost of it, but any additional population acuity, pandemics, cost increases around that. And then certainly the hospital payment model, whether we go into a payment model or not, just the administration of the agreements is a considerable risk, assuming that we get all the data that we need to get in order to administer those agreements. Funding that's required to adequately improve gaps in our system of care. We've begun a lot of discussion in our strategic planning group around our system of care. There are a lot of gaps. There are a lot of improvements that need to be fixed. And certainly the funding, we need adequate funding to address those gaps. The 1115 waiver, there are two risks related around that. Just execution of our DESRIP metrics. We have been really fortunate over the history of the 1115 waiver DESRIP program that we've been very successful. It doesn't get easier as time goes. And again, these are purely performance-based, and they get extremely complicated when you have events like COVID-19 coming into play related around achievement of those metrics. Discontinuance of the ACA, that has always been a risk. It's now in the Supreme Court again, related to the current administration's desire to discontinue the ACA. It's a risk for us because we have estimated there are at least 25,000 residents in Travis County that are enrolled in the ACA that are below 200% of the federal poverty level. So they would certainly fit our criteria for the MAP and MAP Basic program. And that's a lot of members of the ACA that would still require healthcare that our system would need to potentially provide the necessary services for. We've talked about the EPIC implementation that Community Care is undergoing. This is their medical record system. This is a significant system implementation. If that doesn't go right, that creates a lot of issues related around not only the delivery of care, but next steps on how they get into a new system. You certainly don't want to do an implementation twice. You want to do it right the first time, but there's a lot of risk around that. All of these are elements, and this certainly isn't an exhaustive list, but all of these are elements that kind of precipitate the need to maintain higher reserve levels, to both maintain provision of care and mitigate these risks or any other risks that can occur, whether we know about them or we don't know about them. Next slide. I'm going to probably skip really quickly. You've received a lot of updates around the COVID-19 response. There have been a lot of testing sites. There are some contact tracing initiatives that are being evaluated. I would foresee that this item will be brought to our strategic planning committee in August, and there will more than likely be a budget request related around some of the testing and potentially contact tracing initiatives. Next slide. These are our board developed guidance to the CEO and staff that takes us through the 2019 through 2024 board adopted strategic plan. So we see these almost every meeting. Just wanted to, again, point that out, that this is our guiding document as it relates to services. So next slide, and with that, I'm going to turn it over to John Morgan to go through the next slides.
Thank you, Jeff. Manager Greenberg, just a sound check. Can you hear me okay?
Yes, sir.
Thank you. Good evening, managers. Thank you for your time tonight. Similar to the last slide that Jeff just presented, the first slide that I have is a reminder of the proposed FY21 strategic priorities that have been presented in the strategic planning committee, and these are the priorities that really guide the development of the budget and the budget resolution for the upcoming year. Okay. So my comments tonight, I'm sorry, will you go back one, please? My comments tonight are really focused on the first and the third priority areas, including access to care, enhancing clinical programming, and supporting the transformational operational initiatives. I understand there will be a subsequent discussion on the third priority at the next strategic planning committee, so we'll only touch on that lightly tonight. Next slide, please. The next slide should look familiar as well. This speaks to the systems of care planning effort that we are currently undertaking and that will continue to run throughout the next fiscal year. This is where we're taking a comprehensive approach to evaluating our current delivery system components, looking at best practices around the country, and designing our system with a specific view towards health equity, access to care, and the interconnected components of our system. I should also say that this effort includes our organization taking a much more active role in the oversight, management, and improvement of certain components of our system that we have not focused on previously, such as hospital-based services. Will you hit the next slide, please? So as Cynthia Gallegos and I presented last week at strategic planning in quite a bit more detail, we've been hard at work trying to address gaps in services and expanding access to specialty care over the course of this last year. Some of the initiatives that are spoken to on this slide, we've expanded access to ambulatory surgery center services through a partnership with Austin Surgeons and St. David's affiliated surgery centers. That's gone very well to expand access to our patients. We've worked very closely with our partners at Community Care and expanded access by adding a full-time podiatrist and introduced rheumatology clinics within the walls of our FQHC system for the first time. Later this year, we're going to continue to expand access to care by adding nephrology services with Community Care and in partnership with the Dell Medical School. Also of significance, you heard at strategic planning from Dr. Agrawal, who's a gastroenterologist at Dell Medical School. Over the past year, he really led the way in redesigning our gastroenterology care, and his work and his team's work completely eliminated our wait list of more than 1,500 patients waiting for GI services. So we're very grateful for his work. We've had similar success in dermatology, eliminating wait lists recently, and we hope to highlight that progress for you in more detail at a future meeting. Finally, in our work with our partners at Austin Regional Clinic, we've been able to eliminate the ENT wait list for MAP patients, although there's still a significant wait and need for services for MAP Basic, sliding fee scale, and charity care patients. While we want to celebrate our successes and share those with you all in the community, there's certainly still a mountain of work ahead of us. There are still wait times that are at unacceptable levels across many specialties. And most importantly, we know that delays in care result in adverse impacts to our patients, their clinical outcomes, their quality of life, and even can result in premature mortality. As a result, we will be asking the Central Health Board to continue supporting significant investments in specialty care in the FY21 budget and for the foreseeable future as we continue our systems of care planning exercise. Next slide, please. So this slide is really the meat of our FY21 ask related to specialty care. It's a very busy slide. I'll do my best to talk through it quickly. This slide is really an abbreviation or summary of the highlights of the anticipated specialty care work. The list on the left side of the slide is related to the work that we anticipate implementing during FY21. The list on the right side refers to a somewhat longer range plan or set of plans that are still in development and will be part of our future systems of care planning discussions. On the left-hand side, the first 5 bullets represent prioritized areas that we are proposing through the budget to add capacity and improve access to care. In past years, we've generally prioritized 2 or 3 specialty service lines and tried to attack those. As you can see, this year's plans are quite a bit more aggressive. Many of you heard from Dr. Agrawal last week, and the process that was undertaken by his team to improve GI this year is really going to serve as a model for us to add capacity in those first 5 specialty areas in conjunction with our FQHC partners, certainly prioritizing our work with Community Care. We also plan to support increased capacity for psychiatry and for substance use treatment within our primary care settings. We want to call attention to that, as well as outpatient and home-based dialysis services that I spoke to briefly last week. And this is probably the single largest clinical services investment that we're asking the board to make in FY21. Just as an estimate or a point of reference, providing routine dialysis to as few as 50 MAP patients on a monthly basis will cost the organization around $3 million annually once you consider the related clinical services and all the necessary support services. But we think it's critically important. It's been a gap in our system for a long time, where today our patients only have access to hospital-based emergent dialysis that's available only when an individual's condition deteriorates. I really believe personally that this is one of the most impactful areas of expansion that we can undertake this year, just benefiting directly our patients' quality of life. As I mentioned last week, these services can really result in our patients being able to go back to work if they're able to start home-based dialysis. Having routine dialysis helps them avoid further complications related to their renal disease, and ultimately we can extend people's lives. And that's a pretty compelling argument for all of us. I should mention that adding a dialysis benefit to the MAP program would require Seton's approval as a reserve power through the Community Care Collaborative. So we'll have to work closely with Seton as we're working on this. You all are also familiar on the last bullet on the left side with our work with Dell Medical School related to musculoskeletal services. That service was initially focused on knee and hip replacements as well as some upper extremity work, but we're working with the Dell Med faculty who have been great partners to us to bring neck and back pain services and more comprehensive services with a focus on bone health in the coming year. It's important to note that neck and back pain is one of the primary reasons that our patients present at the emergency room. On the right-hand side of the slide, these are really critically important components of our specialty care system of care, but we don't typically call them out specifically when talking about specialty. These services, though, are certainly important in that if we focus only on clinic capacity, then we're going to have inefficient or even completely ineffective specialty care services. For example, on the first two bullets there with diagnostics and advanced imaging, delays in diagnostics and imaging can result in delayed care for our patients. Or even worse, if those services aren't available in a way that is easily accessible, many of our patients won't be able to go. They won't be able to access those services, and as a result, treatment may never start. So these are longer term, bigger system components that we're going to continue to look at over the course of the year. We also have to look at the services we provide to our MAP basic population. As you recall, one of the primary benefits of a MAP basic enrollment is that having an enrolled population creates a platform and the underlying infrastructure that we need to work with other specialty care providers in the community and offer additional services to those patients. As part of the patient population that we strive to serve, the MAP basic population, or what has historically been the sliding fee scale population, has not had access to the same level of service as our MAP enrollees. While we want to continue to prioritize services for MAP, we've now built provider networks that we can leverage to expand access to critical services like those you see listed here. Skilled nursing facility services, home health, urgent care, specialty care services, and pharmacy benefits. These are critical aspects of our system that we have to continue to develop. Moving forward, we will continue to contract for and emphasize services that can take place in the most effective, efficient, and patient-centered locations. Today, we perform way too many procedures in the hospital that don't need to be there. And we're going to continue to look for opportunities to move services into surgery centers, endoscopy suites, or even into office settings that don't need to be done in a hospital operating room. We'll continue to invest in our specialty care infrastructure that's often overlooked, and some of that can be care team staffing, our referral management staff, our patient navigation staff that really help our patients navigate an extremely complex system. And then finally, we'll continue to invest in services like telemedicine and e-consult that I'll talk about a little bit later, as well as I mentioned earlier, take a more active role in hospital-based surgical specialties and even some of the most complex service continuums that we deal with, such as cancer care. Next slide, please. So this is my last slide this evening. I appreciate you all bearing with me. The second strategic priority area that we're discussing more in the upcoming strategic planning meeting, but I needed to at least highlight these three significant investments tonight that are part of the budget. We will dive into these in a little bit more detail. The first two you should be relatively familiar with. We need to continue to support the EPIC implementation at community care. It's a critical investment for our FQHC partners for a number of reasons that you've heard about. You've also heard quite a bit about our eligibility call center function that we're bringing in-house starting October 1. You all approved the lease for that space last month, and then the furniture and equipment purchases related to that space earlier this evening. The one you haven't heard much about up to this point is the medical management bullet. And again, we'll talk about this in more detail, but just a few quick points. This is another sizable investment that continues the growth of our medical management department here at Central Health that we started a few years ago. This is the investment in our patient-facing component of the delivery system here at Central Health. And this is a key component to developing a highly functioning and patient-centered system for our patients. These are the nurses, the social workers, the health management liaisons that connect with our patients. They're in the emergency rooms. They're on the floors at the hospitals when our patients are admitted. These are the folks that are case managing our most complex enrollees and who help navigate our patients, as I mentioned earlier, through a very complex system, including enrollment into other coverage programs when those are available for our patients. Our proposed budget anticipates growth across all of these functional areas in medical management. We're adding or proposing to add 11 additional FTEs, and we'll talk about that more in the later slides of the budget presentation. But this is so we can be more in the hospitals, connecting with our patients as they're in those acute care settings, in our patients' homes. There's a lot of support for the homeless enrollees that we serve through these groups, wherever they need us to help them navigate the system and engage with the system. You'll notice that there's not a space or furniture request related to the medical management expansion, because these staff are primarily in their cars, in the homes, and in the healthcare facilities advocating for our patients. I could spend an hour just talking about this, but I'll save that for a future meeting. Thank you for your time. I'll turn it over to Lisa.
Okay, good evening. Lisa Owens, Deputy CFO. Can you hear me okay? Yep, thank you.
Yes.
Okay. So as we mentioned earlier, this is the first opportunity to look at our slides that have the proposed budget, but we will be back in August and we will welcome requests for additional information as well as opportunities to meet in the next month, answer any additional questions. I realize this is the first time that you're seeing this information. So as Jeff mentioned at the start of the presentation, when we start our budget process, we assess the current year and make year-end estimates. So I'm going to start by providing some information on the second column of numbers here, the 2020 year-end estimate. I'm going to walk through those numbers as an estimate of where we believe we're going to end the year in September. So we do anticipate ending FY 2020 with approximately $297 million sources of funds, and this is predominantly property taxes that have been collected, $214.9 million of that. Our lease revenue was budgeted to include some opportunities for lease prepayments, some of which we did not elect, so therefore we are estimating just a little bit less than budget, about $2 million less than budget in this area. And as you've seen in our financial statement presentations, we did have a contingency reserve carry forward that as an available source of funds in FY 2020, all which total to an estimated $297 million as sources of funds for FY 2020. For the uses of funds, we estimate the healthcare delivery program uses of funds to be approximately $170 million. And through June 2020, our current healthcare delivery uses are just over $101 million. We also anticipate spending approximately $1.7 million less than was budgeted in our administration program. And our total year-end estimate for the uses of funds are approximately $181 million. Our estimated contingency reserve at year-end that will be carried forward into FY 2021 as a source of funds is approximately $115.8 million, and our emergency reserves, which are 15% of our eligible expenses, will be approximately $38.7 million. So if we move over to the proposed budget, as we look at the first numbers in our proposed budget, as Jeff indicated, we do have a property tax rate preliminarily set at 10.8624 cents per $100 of valuation. We are basing a lot of this information on preliminary estimates from Travis Central Appraisal District, although we anticipate the timely reporting by the end of the month from them to update this information for you in August. But that's our current estimate. We did draft the budget at 6.9% over the no new revenue rate, with the possibility of approving the Community Healthcare Initiative Fund that included 0.4% over the no new revenue rate to provide approximately $875,000 in additional revenue for that proposed fund. At this rate, and based on preliminary information from Travis Central Appraisal District, we anticipate an additional $20 million in property tax revenue in FY 2021. We have reduced our budget in interest revenue and tobacco litigation as well as we go into 2021. We are conservatively planning for the impact of the market conditions that could impact those items. So we did lower those slightly as we go into the upcoming year. And then you'll see here, I think if you can see my cursor, we do have the contingency reserve that carries forward from our year-end estimate of $115 million. The total sources of funds are estimated at $368.4 million. We do prepare a structurally balanced budget, so our uses are also $368 million, and I'm going to walk through the details of all of those specific items in the healthcare delivery and administration program on the next slide. So you're familiar with attachment B. This is the details of our uses of funds. If it's a little too small, do you want me to make it a little bit bigger? Okay.
Please, please.
Yeah, I realize I can do that in the, make it a little bit bigger here and take it in 2 slides. Hopefully this helps a little bit. So looking at our proposed budget for intergovernmental transfers, I'm going to really just give highlights on items that are over $100,000 or over 10% variance. So some of the significant variances, that's the highlights I'm going to give tonight. But again, I'm happy to answer questions about specific areas as we move through this process throughout the summer and bring back additional details on any certain areas. So we do estimate fewer funds required for IGT. We're estimating a budget of about $9 million less next year as a result of known changes to the program, as well as based on our current year actual expenses. Going into healthcare services, which is where our network of our contracted providers are in their different areas. Looking at primary care, our proposed budget has an additional $5 million, over $5 million, that is planned to expand services with our primary care partners in FY 2021. And John talked about a lot of this work in his previous slides. So this is the area where you'll see those dollars. In specialty care, we are anticipating contracting with UT Health for services that are currently being provided in the Community Care Collaborative, as well as making incremental increases in our existing specialty care services. And in behavioral health, as you know, we're executing a contract with Integral Care to support COVID expenses for inpatient services, and we're also budgeting an additional $500,000 in behavioral health next year. In the pharmacy area, we also see an approximately $1 million increase next year. And as you've seen in our monthly financial presentations, and we've talked about, in addition to expanding pharmacy benefits to our MAP patients, we have increased our budget, and we will be increasing it again next year in order to continue to possibly expand the available services to patients. In hospital and specialty services, in FY 21, we are proposing a budget of approximately $57 million. And then I would like to just address what looks like a reduction, but it's not. It's a reclassification here in reproductive and sexual health. Our commitment to reproductive and sexual health is the same at $1.9 million. However, we have reclassified about $800,000 just as an estimate of those expenses that are primary care services to be more properly reflected in the primary care line. So in this $5.165 million, you'll see that that $800,000 was just reclassified in order to appropriately reflect the services being provided. And then and another area where there is a change is this proposed Community Healthcare Initiatives Fund, as we've talked about and was mentioned earlier. When we calculate an additional 0.4% of tax rate, it is approximately $875,000. And the board would consider approving this in the budget process. So looking in the next section, which is our healthcare operations and support, first I'll address some of our larger programs here, which is our investment in ACA high risk and the CHAP programs. We are proposing an increase to the budget year over year of approximately $1.6 million to account for potential increases in premiums or additional enrollees. And then in our real estate, healthcare facilities and campus redevelopment, which includes a lot of our real estate investments, we are decreasing that budget. As you have seen in the current year, the expenditures have begun to decrease. We're well under budget, that $10 million budget this year. We have less expenses on the campus as the campus operations have completely wound down, and we are now in demolition mode. So that accounts for some of that. But this line item does have funds for continuing that demolition and additional possible professional services that we may need for new real estate projects. The next area I'd like to focus on is really a section here that is salary and benefits all the way down to other operating costs. So this section looks very similar to the administration program. And this is really where our healthcare delivery departments are budgeted in summary. So this is the combination of the multiple healthcare delivery departments that we have in Central Health. I will be bringing back in August and more information about salary and benefits. I know the board had asked last year to see additional information about number of FTEs. So I will bring back additional details on those line items at the next meeting. But I just wanted to hit a few highlights in the healthcare delivery departments. We do see some significant investments, as John spoke about earlier, in our medical management program and the call center that has been approved. So there will be an increase in staff to support those functions, and the salaries and benefits are included in there, as well as a process that you may recall or have been presented by Mr. Giesland multiple times to the board that was rolled out internally to approve business cases. So we undertook a significant business case planning process for any new initiatives in Central Health. Business leaders brought forward their business cases and they were evaluated. And so you will see that those business cases, as they were approved, are incorporated in this budget. And some of those are in salaries and benefits. Some of those are also in other professional services. And again, as I mentioned, I'll bring back more details on number of FTEs and the new business cases that were put forth. But as an example, I'll just reference again the medical management team that John spoke about was one. And so that is an example of the process that went through those. Business planning is now in the budget. So I'm going to move down into reserves and appropriated uses and transfers. As you know, we maintain a capital reserve. I have 2 slides on that later in the presentation, so I'm not going to go into great detail right now. And as mentioned earlier, we do prepare a structurally balanced budget. So we have appropriated contingency reserve in the healthcare program of $87.9 million. And also included a proposed hospital services reserve as we're contemplating model with potentially more risk. We think it would be prudent to establish a reserve over the next several years, and we would be bringing forward a financial policy later this summer to support that type of reserve. As you're aware, each of our reserves have a policy that supports them that has been approved by the board. Quickly, our debt service, we are budgeting less as a result of the refunding that you all are aware of from earlier this year. So our interest is significantly less going into next year for our existing debt service. And then hitting some of the highlights on administration, again, you'll see the similar functional categories here. As I mentioned, we do have additional salaries and benefits in here that were approved by business cases that were approved, as well as other professional services for components of those business cases that were approved. And as I mentioned, we'll bring back more information in that area as we go into the next meeting. And finally, just a slight increase in the appraisal district services and tax collection expense. So again, total uses of funds at $368.3 million. I'm going to switch back to the view. Go on to capital reserves. So we do look at our capital reserves just for next year as well as long term. So I have a couple slides here. We estimate that we're going to end this year with 6.2 in capital reserves, and that we could potentially have capital expenses of $22.5 million next year. We made these estimates based on possibly 2 or 3 new clinical locations, also the Red River realignment, and the continuation of our support of the electronic health record transition, the EPIC project that you've heard about. And we are increasing that capital reserve or support of that project to support an additional $1.5 million in the FY21 budget. And that additional investment would be combined with the investment approved $8 million from last year. And then looking at this from a longer term view, again, well, I'm going to go back really quick. I just wanted to point out, we do anticipate that some of that $22.5 million would be debt financed. We've flagged some projects that we think a portion could be debt financed, and some of it would be used from our cash reserves. So we anticipate ending the year with a cash reserve of approximately $5.8 million. And then again, this is the longer term look that you saw when we presented the long-term 7-year forecast. And then going into the last component of the presentation that I have tonight, or the second to last, I'd just like to hit some highlights from the CCC budget. As you know, this board also approves the Community Care Collaborative budget. So we do have a preliminary proposed budget for the Community Care Collaborative. Sources of funds are limited to the DSRIP payment next year, and other would be interest or just earnings on investments. And then a contingency reserve carry forward, which is estimated to be $10.4 million. So total sources for the FY21 proposed budget for the CCC are $63 million. And then looking at the uses of funds, the uses of funds are in alignment with what the categories that you've seen in the current financial presentations. However, as I mentioned, as the sources of funds are less, as the DSRIP revenue, as we know, is planned to decrease over time, we have, as I mentioned, planned to contract with some specialty care providers such as UT Health in Central Health next year. So you do see a reduction there that is accounted for in our planning for specialty care services based on those service lines. We also, so total healthcare delivery for services and operations at $15.9 million. We have a FY21 budget for DSRIP project costs of $12 million and the UT affiliation agreement at $35 million. So total uses of funds in the proposed budget for the CCC, $62.9 million. And lastly, the calendar. Again, this is our first presentation of the numbers. Appreciate your patience as we got those out today. We will be back in August. We have a meeting August 19th, and we will be available to answer questions regarding any of the numbers as you've had time to look at them or this evening. And as we move forward in August and early September, the calendar is still very busy as we anticipate our public hearings and the setting of the tax rate, which includes presentations to the Travis County Commissioners Court. Our goal is to present our budget to the Travis County Commissioners Court September 22nd, so that we have it approved and the tax rate approved well before the September 30th deadline. And with that, I can, or John and Jeff can also answer any questions. Sorry, hit the cursor.
Thank you. Mr. Giesel, did you want to add anything else?
Yes, members, as you see here in this calendar, there are many more opportunities to have discussions around the proposed budget, but we wanted to take this opportunity tonight to present it to you with the necessary context, which we spent a lot of time on, more so than what we typically do, so that you can see what's driving this budget. And I want to thank staff and everybody that, and some people that haven't even presented tonight or may not even be on the call, that have just really worked tirelessly, especially in a disrupted business environment, especially because we've added some new internal processes around building business cases to be able to pull all this budget together. So thank you very much.
Well, thank you very much. Very comprehensive presentation. We appreciate everything that you are doing, all the staff, many of whom we don't see or hear from, particularly with the amount of hours that I know all the staff are putting in across our enterprise with the COVID situation in this. And I really appreciate the emphasis on increasing services and service delivery. And John Morgan, your discussion of what we need to do. We discussed this system approach in strategic planning, but coming back to that and coming back to providing more of these services. Members, I know we still have a couple of items on our agenda this evening, and this is just our first presentation on the budget. So if anybody has any quick questions now, certainly speak up, but I would encourage you to take time to study this, and staff has been very gracious, Lisa and Jeff and others, about their availability to have follow-up meetings. And again, just contact Brianna to schedule those. So with that, are there any questions at this time? Manager Valadez?
Just one.
Mm-hmm.
Let me get myself. Oh, just one. If you can go back 2 slides, I think. Lisa. One more. More. Again. It was where you had the 20 approved budget, the 20 actual budget, and or estimated this one. So down here in healthcare delivery uses, is that about $100,000 less? Is that 100,000 less? 100. I can't see what it is. My eyes. On the uses, why the big discrepancy from the approved budget to the year-end estimate?
So we are estimating to spend less in healthcare delivery, and I see Jeff coming off mute, so I'm going to let him.
Yeah, I think, thank you for the question, Manager Valdez. I think the biggest component of that estimate, we had a large budget in our fiscal year 20 budget related to hospital payments. Again, we were trying to we're in mediation with Ascension, Texas, related to a more direct payment model for hospital services. We don't anticipate entering into an agreement for fiscal year 20. And so that was a large item. That was the hospital amount was over $50 million. There was a performance incentive related around that also, which was 2.7 million. And then there was a post-acute amount, a commitment that we had been discussing that if we don't enter into an agreement, we won't make. And that was, I believe, around a little over $5 million. So that's what's driving a lot of that. Our intergovernmental transfers were less also as part of the COVID-19 event. CMS enhanced what's called the FMAP rate. So that's the match rate that you get from your local funds. And so we ended up doing less intergovernmental transfers related to that enhanced FMAP rate. So again, that's a higher rate of match that you get for local funds. And since, for example, our desert funds are a fixed amount, it just meant we IGT'd less. And then DISH is always, disproportionate share is always a hard number to know exactly how much it will be, just based on all the different variables and factors of it. And so the disproportionate share intergovernmental transfer was also much less.
I thank you. I appreciate that stab at it. That's $100 million less than healthcare delivery uses. And I'm sitting here looking at the COVID. I'm looking at the lesser amount of money spent on our MAP patients in receipt of specialty services and other things that they might need. And I'm just curious about that and wondering if someone can later on, not today, get with me to explain why we're spending $100 million less in services. I think I just need to have that justified as to whether or not, and no way of spending it between now and the end of the year. And especially in light of the fact that I know community care is looking at a deficit in budgets.
So Manager Valadez, if I heard this correctly, Mr. Knodel, sounded like the majority of that had to do with Seton Ascension and mediation. Is that correct?
The hospital services
The
budget.
hospital services, yes. Yes.
The actual care being provided to our patients, correct?
No.
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 Okay,
No.
then I'll if someone
I think you should take this up offline. Yes.
Yeah.
Can I say real quickly, Chair Greenberg?
Yes, please.
For COVID-19, we have hired a consultant to help us navigate the complicated reimbursement processes that you need to go through related to COVID-19. And just as a reminder, community care has received a couple of different tranches of funding related to COVID-19. I think aggregately it's about $5.4 million. But we're always looking at any other funding that they might be eligible for. And I think our consultants are going to be really helpful as we try to maximize both our spend on the services side, but also go through a reimbursement process. So thank you for bringing that up. I just wanted to assure you we're trying to work through a reimbursement process as diligently as we can.
Thank you. Members, any other questions at this time? I'm trying to look. Speak up if I don't see you as I'm scanning through. If I do not hear of any, then we will move on. We will be spending many, much more time, much more quality time on this too. And again, the opportunity offline to have follow-up meetings with staff on this. I'm not seeing any at this time, so unless I hear somebody shout out, we will move on at this time to agenda item number 5. Agenda item number 5 is receive and discuss updates on the Central Health Enterprises responses to the current COVID-19 pandemic, including basic reports on services, coordination, and outreach with and among Central Health, Community Care, and Sendero Health Plans, Inc. And with that, I will turn it over to some community care staff. John Morgan, Sarita Clark-Leach will be presenting.
Yes, and I'll actually, Chair Greenberg, if I could just chime in here to lead off.
Yes,
and I think
please.
within an hour, and I'll provide some guidance here to some of the presenters. What we really hope to do tonight was just, because we spent a lot of time on the COVID response last week, come back this week and just give some quick verbal report outs in terms of where we are to see if there's any major changes. I will say from a community standpoint, it seems that the focus is on an alternative care site to be with a go live date of 21 July. Remember, this is a care site that is outside of a traditional hospital setting. Really trying to improve the data sets that are presented to the state, and this is the second point, to back up resource requests from the state as it relates to providing healthcare operations. And again, contact tracing and testing, and more specifically with that, with community care and Central Health focusing on the community care positive testing patients. And then of course, our community outreach that continues in multiple channels in culturally appropriate and linguistically appropriate ways. So that's that seems to be the overall focus. But I will say the one thing that has changed since the last time is a more intense focus on the ICU capacity. We are nearing some critical levels at that point, and hence the reason for trying to up these resource requests to the state and to smartly manage what that ICU capacity is going to look like. But we're going to report on that as times change. So please be watching your emails for written updates or email updates should that situation change. So with that, I'll quickly, Jason had to actually take another phone call and was not able to stay on the line. I see Dr. Schultz is on the line. If you don't mind, Alan, I'll flip it to you to see if there's any quick updates on testing. And then if you would send it to John Morgan and Sarita after you're speaking.
All right. Thank you, Mike. The only transition that we've made over the past week is we've gone from asymptomatic testing for people who have been exposed to COVID to align more closely with APH and are testing only symptomatic individuals. The labs that we have been utilizing are overwhelmed. And so the turnaround times have really extended. We're looking at all opportunities to contract with alternative labs. But just really testing symptomatic individuals, those individuals are tend to have our highest % positivity anyway. And so we've transitioned over the past week, and I'll stop there. Thank you.
Manager Greenberg, can you hear me okay?
Yes, sir.
I know we need to be brief. I'll turn it over to Sarita very quickly. Her team has been working on trying to give the board and our team here at Community Care and Central Health better insight into the positivity rates of the virus for our patient population. That is a much more difficult task than it might seem at the surface. With the limited amount of data that we have, we're trying to make some estimates that are reasonable and that are substantiated with the data that we do have. Sarita has been looking at the testing data related to community care and the 20,000 plus tests that they've performed, and then trying to extrapolate those positivity rates to get a better understanding of how the virus is impacting. So I'm going to turn it over to Sarita, and she can speak to some of her preliminary findings related to that.
Thank you. Sarita?
Hello, everyone. I don't have a presentation per se, but I wanted to talk about some of the findings. So CUC tested 2,817 MAP and MAP basic patients between the dates of 3/11/2020 and 7/2/2020, and they averaged about 60 to 70 tests per day. From those tests, we saw a positivity rate of about 26.5% for all of our MAP basic enrollees tested. And I would really like to advise anyone listening to this not to generalize that positivity rate to our entire MAP basic population. We're still working to figure out, how we can do that. We may require hospitalization rates, death rates, and other data details to sort of back into that more generalized estimate. For the last week of testing that we looked at, which was 6/26 to 7/2, we saw that the positivity rate was at about 36.4%, and we ran a regression model on that and found that in the upcoming weeks, and that's everything staying as they are, and we know that in this environment that's generally not the case, but if we continue to test at the rate that we're testing, that rates are going to continue to increase in the next few weeks. Some other big takeaways were that Latinos were overrepresented in the population both in terms of who was tested and then in terms of positivity rates. 73% of enrollees who were tested were Latino, and they accounted for 85% of positivity rates. And their positivity rate, again, for that entire time testing period of 3 months was 32.9%. For Black enrollees, they were not overrepresented in the population, but their positivity rates for the entire testing period was relatively high compared to their portion of it, enrollees in that population, which is about 7%. But this could be an effect of a small sample size, so we'll need additional data to really suss that out. And some of the more interesting details: sex at birth, we had 59.5% of folks tested were female, 40% male, and 1% unreported. Of those who tested positive, 61% were female, 38.9% were male. And so that's an interesting skew, and we're still looking into that. And those are the high-level takeaways that we have. And as we continue to get more data and different kinds of data, we'll improve our reporting and be able to share with you additional breakouts and information that you can generalize to the wider MAP population.
Thank you very much. Was there anybody else who was wanting to present? Well, thank you. And I know this is difficult with not getting the test results as quickly as we were. That's really slowed down, so that slows down the data. And as you said, you have small sample sizes in some of this, but we really appreciate all your hard work. I saw some hands go up. Manager Zuniga, I think, was first. Oh, wait, Mr. Giesland, did you have something you wanted to add?
Yes, just real quick. I wanted to pivot to Ted Burton to see if there was
thank you.
Have been any developments that needed to be brought up to the board.
Ted, is there anything you need to add?
I don't. We covered it last week. I could just quickly say that our business outreach to minority-owned and managed businesses will begin this weekend, so that's underway. But that's all I have.
Okay. Manager Zuniga.
Yes, I was wondering if staff and healthcare providers are still reusing masks and if there is a plan to increase the stock of PPEs.
Happy to take that. Thank you. Great question. We are reusing masks. I think all of our dental staff actually have, as far as the N95, are allocated 5 masks. And that way they utilize each mask greater than 70. So they utilize it, let it sit for greater than 72 hours, which means the virus dies and they can reuse those masks. For surgical masks, individuals are getting new masks on a daily basis. We actually do have significant N95s in right now, but would never say no to any additional supplies. So as of today, we are not short of PPE and feel that we're protecting our staff, as well as we possibly can. But great question.
Other questions? Manager Jones and Manager Musaitov, then Manager Valadez. Manager Jones, you're on mute.
Yeah, okay, thank you. Dr. Sasha, you mentioned that no testing on asymptomatics, only symptomatic, and I understand the rationale behind that. I guess my question is, do we have any profile in terms of, based upon the numbers we've seen, by race or ethnicity of asymptomatic versus symptomatic? Of those that we've already seen.
It's a great question. I don't think we've broken it down based on race, but not separately based on asymptomatic with exposure and asymptomatic without exposure. I think one of the things that we did see were our asymptomatic. So going back a few weeks, the rest of the community was not testing asymptomatic individuals. The reason we were testing those individuals is both because the CDC advised it at first and then withdrew their recommendation, and because we had discussions with APH and the populations that, for which we serve, really have a much higher percent positivity than other general populations. And so together we felt that we should be testing asymptomatic individuals just because of exposure. Now, since the labs have been overwhelmed, we really are trying to target the highest percent positivity. So indirectly, so I can't answer your question because we haven't looked at that by race.
Okay, well, no, I appreciate your attempting to address that. A second question is, and this may be to Ted, has the Pflugerville location, has that been addressed? I understand that the walk-up clinic was eliminated and that we were seeing clients at our clinic in Pflugerville, but no one else in the other areas. They had to go outside of the area. Has that been addressed either by APH or anyone else?
Mike, do you want to address that?
Yes, and I'll ask Alan to confirm that what I'm saying is correct. So if you're a patient at community care there at the Pflugerville clinic, you can still get tested at that clinic. What was changed was the drive-through there at the community care clinic site in Pflugerville, in part because it's joined up with the building, as that the county owns and that there are services there. And it just got to the point that because they were using the clinical staff to do that testing and with the traffic and safety issues, that they needed to relocate. So to community care's credit and the central health team's credit, there were some discussions with Austin Public Health on how to better coordinate those services, that testing. And I know that Austin Public Health is looking at utilizing one of the sites that community care was looking at to set up testing. And I think one of the positives with Austin Public Health bringing those resources to bear in Pflugerville is that I think they can bring more capacity for testing than what community care was able to do. That's not a slight against community care. It's just the nature of the way resources are commanded at the local authority level. So I'll pause there to see if there's any additional information.
Dr. Schulze.
Manager Jones, the APH thinks that they could do a minimum of 500 tests a day, which is much more than we could do. So potentially test up to 1,000 when they get up and running, which should be in the next couple of weeks.
I appreciate that. My concern, though, is that for the last, as I understand, last week and now this week and maybe a couple more weeks from now, populations out there, which there's a significant African-American population, has to leave the area to get tested. Unlike in other areas of our county, we do have at least some sites. So I don't know if this is a question I should be asking APH or other, but when can we anticipate services out there for non-Central Health clients?
Ted may know more accurately than me. It was 3 weeks, about a week and a half ago. So I haven't, checked lately, but their testing site, I think, should be up in a couple weeks, and that is open to anybody.
Okay, is there the likelihood of exposure, greater exposure there because folks are not able to get tested, particularly in that quadrant of the county or that part of that city? It's the second largest city in the county, by the way.
Definitely the more we can test, the more we can inform, the more we can keep people home. So, it is definitely not positive that we're not doing active testing. To my, we're happy to test them. We can't handle the capacity based on the size of the clinic.
No, I understand. And that's why I said maybe a question for APH, and I'll follow up with them.
Yeah.
I was just, my last question is to Sarita. You always have great answers. You mentioned that Black patients have higher positivity rates, but their numbers are real low, so you can't make a correlation between the numbers necessary and the rates. That's a concern, particularly when we look at places like Pflugerville and other parts around the county, is that maybe the numbers are low because they can't get tested. And are we contributing to the problem we're encountering here?
So I think the latter question is the one that I can't really speak to, but for the first part of the question that you asked, yes, we can't really, with any statistical rigor, say that the values that we have, the positivity rates that we're calculating now for the Black population are accurate to date because the sample sizes are small. So, and we imagine, and there's another issue at play here as well, because, there's a lag, right, from the test date to the test results. So if patients are present and are asymptomatic or asymptomatic and don't have known exposure, their tests aren't prioritized. So this could be just a matter of us not having enough data at the time that we pulled it and the test results coming back. But insofar as whether the Black population are being tested adequately, we still, again, unfortunately, we need more data to determine that.
And my concern is, and I'll talk with APH, is that particularly for the African American population, we're not getting a real reflection of what's going on here in Travis County. And that's a concern, or should be a concern anyway. Thank you, I appreciate it.
Sure.
Indeed, yes, I would be interested to hear, Manager Jones, what you ascertain. Manager Musaitov?
Yes, thank you. My question is, how long is the process, how long does it take to the turnover to get the labs back?
It's ranging between 5 and 9 days. We're able to prioritize about 300 tests now, and we get those back normally within 72 hours. We have actually, the number of tests that we've done over the past few days has actually decreased. And so for the majority of the tests, I think we're going to start getting them back much faster. APH had similar problems, and so is investigating other lab sources. But it's
Well, the thing is, I've been working on contact tracing for the past couple months with the state, and I've noticed this lag. It's from the time that the sampling is collected to the processing time. So the average, it varies from one lab to another, but the problem that becomes an issue is with this transmission period of time that we cannot control when the moment that an individual is notified or not, if their status. And I just don't feel we're doing a great public health job. And it's not your...
So let me, Manager Musaitov, let me interject there. It is clearly the case that the faster we could turn around those tests, then the more that we can do contact tracing. There's no doubt about it. But I know that this has been an issue for Austin Public Health, for Austin Regional Clinic, for us, for others around the state. And I know that community care is doing everything it can to investigate other labs in any which way that tests can be turned around faster, because yes, the faster you can get those results, then the more that you can actually do meaningful contact tracing. So
oh, absolutely.
Everyone is keenly aware of this issue. Do have, Dr. Schultz, I do have a question. When you said that there were, I think, around 300 that are prioritized, what determines whether somebody's test falls into that priority bucket?
Symptoms, yeah. So those folks that had positive symptoms were getting a higher priority. We were just running out of the number of flags.
Right.
Yep.
But now, and now we're only, community care is only testing symptomatic, right?
Correct.
So let's say that you have 500 symptomatic that you're testing. How do you prioritize 300 is my question.
So they actually are almost like flags. And so it's a very manual process. As you send the sample, you just put it in the bag. When you run out of the flags, you run out of flags.
Got it. Okay, that answers my question. Thank you.
So if I may continue.
Yes.
Again, I have no doubt of the work that community care and everyone else is doing. It's a lab issue, I've noticed. So it's common all across. So we're not unique in any way. The other thing that I have in terms of, I know we are reaching ICU capacity within our community. My concern is for our patient population, and is there sufficient care for them, and are they able? Because I've heard from others in terms of getting into the hospital has been an issue, especially for insured individuals. So what are our patient population doing to get hospital care if needed? So what are the issues? Like, how are they getting the care? Are they being turned away? Are they being
who's best to take that question?
So, yeah, I'll turn it over to John Morgan, and then if Dr. Salsa from the standpoint of community care wants to opine as well. But before I turn it over to John, first, this is an exercise of smartly managing the capacity. And what we have been vigilant about is to make sure that at no point that the payer source becomes a factor into who gets care. And so far that has not been the case, but nonetheless, we remain vigilant on that. The second is by having staff that are participating in the alternative care site task force. Again, we have insight into that to know, all right, when the hospitals start reaching that critical capacity, then what's going to be happening in that alternative care site to make sure that the quality of care is one, what it needs to be, but two, again, payer source neutral, and three is for the lower acuity care patients, meaning you're reserving the hospital capacity for those that have the higher acuity. So there's many more factors in that, but I'll turn it over to Mr. Morgan to see if he has any additional comments to make that's responsive.
Mike, I think you made the points that I was going to make. I think we have not heard that payer source or funding source is a determinant in where people get treated or how they get treated, or if they get treated. But I do think, to Mike's point, we are embedded and part of the right conversations that allows us to continue to monitor that going forward.
And, if I may impose, if I could just interrupt real quick, as the communities in the public health authority and the hospital officials are starting to focus on ICU capacity, one of the calls that you'll see coming out and we'll need to be persistent about is for additional staffing, and especially nurses and other allied health professionals that are critical to supporting both ICU as well as on the floor inpatient care. And so we'll be pushing that out to you all to the extent that you can use your social media networks and other connections to get that message out there. Please do so. But that'll be coming up probably later this week, and over next week you'll start seeing more messaging around that. Thank you.
Yes, thank you for adding that, because it's not just the number of ICU beds. You could have beds, but if you don't have particularly the level of ICU nursing that you need. Dr. Schultz?
Sorry, there was just one more thing where I think education for our patients is critical again. APH and I think the hospital EDs have been getting out messaging, really encouraging patients who are short of breath, who are having chest pain, to attend the ED. because the stats are showing that ED visits are significantly down because patients are afraid to go, and patients who qualify to go are afraid to go. And that may affect our specific populations, equally at least, if not more, because of the fear and the lack of information. So if we can do anything, just, providing education again and saying, letting people know you're short of breath, your chest pain, anything you would normally report to the ED for, you still need to go to the ED. And maybe we save some lives that way.
Thank you. Great point. Managers, other questions at this point? Manager Valadez? You're on mute, Manager Valadez. You're on mute. You're still on mute, Manager Valadez.
Yes, Sarita, if you're still with us, or Dr. Shalsha, if you can provide us whatever it was that you spoke to, because I don't have anything in my backup materials, I'd like to see that. And if with respect to numbers, I would like to see numbers. You can put the statistic there, but I'm interested in numbers because a number is a person. It is a life. And who I am not seeing go to the emergency room are Latinos, especially Spanish speakers, especially those that may have a question about their status or be in blended households where some are citizens and some are not. So that is my concern. And it continues to be a concern because I think there's really a huge undercount of Latinos.
Thank you, Manager Valadez.
I am going to reiterate that I do believe it is necessary that if Central Health or Community Care have a voice with Austin Public Health, that they make sure that they know that a Latinx strike force means Latino. It doesn't mean 3 out of 12 people from the professional arena are it. And so I have to make that point because a Latino strike force means a Latino strike force. That's an insult for anybody to think that anything less is deserving of that name. And one more thing, I would also like to know, sir, and I want to thank you all. I can't thank Community Care enough. I think you all are the ones that are saving us to the extent that you possibly can. But we have many, 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 many people that are not coming to doctors, that are not getting tested, that are actually, many of them are leaving this area, okay? And they're getting very sick. They're making other people sick. They're infecting family members and friends, and their deaths like you wouldn't believe, okay? So I think this is really a sad state of affairs. And I pray to God that if there's anything, sir, that you think that we can do, that you tell us about it. And that's why I have to say, I really would like to see the development and the implementation of at least, because it is so specific to a non-English speaking Latino population, that we get people who are in those worlds to talk to us and to make recommendations for what planning needs to occur and what strategies need to be implemented. Please.
Manager Valadez, just want to interject one thing. We didn't have backup on this in our agenda because we had so much last week.
I understand.
Of the different numbers and statistics and reports, and there's the dashboard you can get to at the city of the county, and also Community Care's dashboard. So this was really just a verbal report out. And of course, we all share the concerns, and particularly, and I know Ted Burton has been on this call, but the concern about those who may not be seeking help or going to the ED because, as you said, they have concern about their own immigration status or someone else's. That is something that we're keenly aware of. So thank you for that. Dr. Shalsha, did you want to respond, or Mr. Burton?
I don't think I have anything substantial to say. I heard the points, and we'll convey the message and information when we have it. Thank you.
I think my point is
Ted,
action.
did you have anything?
Action is needed. That's my point.
Ted, did you have anything you wanted to add? I know we're doing substantial outreach in the Latinx community.
I don't. All the messages are heard, and thank you.
Okay. Manager Jones has his hand up. Yes, Manager Jones.
Yeah, I just wanted to emphasize, I agree with Manager Valadez and others that this has disproportionately impacted the Latino and Latinx community, by all means, not only here, but around the country. But I'm also sensing, and I hope I'm not hearing it right, that that's the only community that's being impacted.
No.
And that's that's why I'm asking the questions, is because what I heard tonight is that we can't ascertain that. True, the numbers are higher in the Latino community because there are larger numbers, but the rates are higher in the African American community because those numbers are. So are we assuming that because the numbers are lower that one population should get less than the other? I don't think so.
No, Manager Jones, I don't think anyone is assuming that. That goes back to a comment I made earlier that unfortunately, and Sarita can probably jump in here, that as you're alluding to, Manager Jones, the sample size is too small with the Black population.
That's my point. And I
agree.
I spoke to several reasons that may be contributed to it. We have a Latinx task force, I understand, which is fantastic. Do we have an African American one? Do we have efforts that's targeted specifically that? I have no problems with addressing the Latinx because I think that is the largest problem. But I know that based upon other chronic diseases, what we see always is that the percentage of the population or the rates in the African American community are disproportionately impacted. So I just want to make sure that as we set up strategies, that we just don't forget or eliminate or not focus, because of what I heard tonight is we're not doing something in the largest area in this county has African Americans. It speaks to the point I'm making.
I concur. As I said, the small sample size, it's a huge problem in the Black population. And Mr. Giesland, what I would ask from you is there anything that we can do? Because I share the concern of, unfortunately, Communicare didn't have that kind of capacity in Pflugerville. Is there anything that can be done to speed up access to testing in Pflugerville?
So that's something that we will take back up again with Austin Public Health, and we'll resume the conversation. Well, the conversation's been ongoing, but
I know it has.
From last week when that decision was made. But members, if I could just say this, it's testing and tracing is important because for purposes of surveillance, but also from an equity standpoint of knowing where do you put your resources. And if you look at Central Health as a hospital district, I want to be real clear about this. We're not the public health authority. There's just certain authority that we do not have under the government to be able to command resources. But the one thing, or actually there's a few things that we can do, but I would say probably our most effective weapon to against this virus is to make sure that we have culturally appropriate outreach through all different channels, especially those that are on the other side of the digital divide, and to keep that up. And I want to give the team credit that's on this call, and also those folks that are inside community care as well, that are part of that communications and that outreach and engagement effort. But that's something that we are going to keep up. In part, Manager Jones, for the very reasons that you pointed out. I mean, there are some communities that, the demographic numbers may be different, the testing prevalence or saturation may be different, but we don't need the testing numbers to know that we need to reach out to those communities and make sure that they're protected. And in fact, you've been part of those efforts and helping us make a video, so we appreciate that. But
Absolutely.
Anyway,
Absolutely. I think we've heard time and time again, and from Dr. Shalsha tonight, that communication is one of the biggest things that we can be doing, and we do. And I want to thank all the board members and all the staff who are constantly involved and others in our ongoing communication efforts. Mr. Giesland, I was just saying that maybe you could run up the flagpole to Austin Public Health, the sense of urgency that this board feels as far as getting that testing up as quickly as possible in Pflugerville. Manager Musaitov and then Manager Valadez, and there we are.
Well, thank you. Mine is really a comment. I believe every community is important, and we're all here at Govern to take care of everyone who needs care, and everyone is important, no matter. So whoever needs our services, regardless of your color, race, we're there for you. I just want to make that statement very clear. Thank you.
Clearly, that is the goal. We are here to serve those who most need our care. Thank you, Manager Valadez.
Yes, and I hope, Manager Jones, that you are not taking offense at anything I say. I was making a comment about the Latinx strike force that is a misnomer. It does not exist. Okay, so that's my point. It doesn't exist. But what happens, and this is a reality, is when you do not speak the language of the majority population that has access to resources and to information, that's a huge additional barrier that goes to the quality of care that they're going to receive, and it goes to the amount of resources that are dispensed merely because they are silent. You don't see them, you don't hear them. And so what I serve here on this board is just as a voice for the people that you are not hearing from. And do not misinterpret my words as being that one population is less or more than the other. We are all equal, and our targeted population is the most impacted. Okay, I don't care what color they are, what language they speak, but the additional barriers to overcome are mostly incurred in those that don't speak this language. And
Thank you, Manager Valdez. Okay, managers, is there anything else at this point? If not, we will move on to our next agenda item. Yes, Sarita Clark-Leach, yes, please.
I just wanted to address something, Manager Jones, and I apologize if I created a misperception, and want to just clarify that when I talked about a small sample size, I was referring to a subpopulation within. So these are only folks who were tested at community care, and then within that population, only MAP and MAP basic patients. So insofar as more generalized testing that's done elsewhere, testing that's done by APH or other organizations, I wouldn't be surprised if there is enough information there to speak to positivity rates of the Black population. It's just that for the specific subpopulation that we were looking at, those numbers were too small.
Thank you for clarifying that, because I think it's important that people realize that the data that community care is collecting is our patients. And so I know some people have gone, for instance, to the dashboard that community care has put up and extrapolated to the entire county. And I've had to tell them, no, that data only pertains to community care, and those are not numbers from the entire county. So thank you for clarifying that.
Yeah, thanks very much. I appreciate it. And I'm not saying this is a central health role. I do believe public health should be taking more of a role in it. I'm not questioning that. What I am questioning, though, within the parameters of those things that we do have control over, we need to ensure that we are not leaving them out. Now,
of course,
I emphasize Pflugerville because we were doing something there in Pflugerville. We stopped it. And Pflugerville has the highest number of African Americans in this county. So I am concerned. I'll talk with public health, as I said earlier, but let us not neglect our role either.
Of course not. Thank you, Manager Jones. Okay, managers, if there's nothing else at this point, then we will move on to our next item, which is item number 6. Okay, so item number 6, receive and take appropriate action on a report from the President and CEO on Central Health's current activities, operations, procurement, and workforce, including related goals and objectives. I will turn it over to Mr. Giesland.
Yes, Madam Chair, thank you. Members, I know it's a late hour, but let's just have a quick conversation about how to proceed on this item if we could. This is a lengthy report, and if you'll notice, it focuses on 3 areas, some quick operational issues, but more importantly, cultural issues and related to our workforce and our vendors, but also some follow-up items from the CEO's evaluation. This is important information, especially some of the turnover rate information that Susan Wildershot put together. She's on PTO, much deserved PTO this week. But what I would recommend is that, you have this report. I would like to have a lengthy discussion on this and do it justice at the August 19th board meeting. In the meantime, I would appreciate any phone calls or questions that any of the members may have. If that's okay, because otherwise, I could cover it in 5 minutes and it just won't have the effect that it needs to have.
So then let me make this request, and that is that everyone please read this information. reach out to Mike if you need clarifications, but also David, if we can, when we are devising the agenda for August, that this be up at the beginning, because if not, I know what will happen, right? And so we need to have this item up at the beginning of the agenda so it gets, you're a lawyer, due process, right?
It will be at the
Mr.
beginning.
Giesland?
Yes,
That,
it'll probably be first.
Is that an acceptable suggestion?
Yes, thank you for considering that. Thank you.
Yes. So this will be first, so that it, we will really need to give it the time that it deserves.
Thank you.
Mr. Giesland, did you have anything else at this
No,
time?
with that, then I'll, again, I encourage you to read through this. There's a lot of information here, and
Yes.
Please ask me questions in the meantime, but I look forward to a hearty discussion when we come back on the 19th.
Okay. All right. With that, item number 7, confirm the next regular board meeting time, date, and location. Managers, our next regularly scheduled Central Health Board of Managers meeting is tentatively scheduled for Wednesday, August 19th, 2020 at 5:30 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702, and/or remotely by video conference, depending on the status of the governor's disaster declaration and stay-at-home orders. Members, at this time, I'm ready to accept a motion for adjournment. Manager Valadez?
I'll second.
Move that we
You're
adjourn.
on mute. Okay, and Manager Oliver, second. All in favor? Aye.
Aye.
Opposed, same sign. Any abstaining? Members, thank you once again for your time, your attention, your dedication, and your very productive discussion. And thank you to all the staff who participated in this, whether you were here or not. And thank you to all the members of the public. We appreciate each and every one of you. Good night, everyone.
Thank you all. Thank you, members.